So today's session is on motion management. It's going to be great. So I just want to introduce our educator for today. So our educator is Trevin Trotman, if I've said that right. So he's from Memorial Sloan Kettering Cancer Center in New York, in the US. And he's a radiation therapist who has loads of experience in his field. And he's going to teach us a lot of stuff today. So thanks for your time, Trevin, and I'll let you get on with it.
No problem. So like Claire said, my name is Trevin Trotman. Just quick backstory. I work at Memorial Sloan Kettering in New York City. I also trained there first, and then I started working as a staff therapist. And then I went up to being a supervisor now in the same institution. So in terms of radiation therapy, Memorial Sloan Kettering is all I know, but I'm pretty sure radiation is all the same across the universe. Like Claire said, if you have any questions, you can stop and ask or put it in the chat, and I'll try to answer as much as I can. I'm going to keep this lecture, of course, radiation therapy related. So anything outside of that, I might need help, from if there's any MDs or because it's online. So we'll get started. Motion management. All right, so motion management can be a very challenging topic. So first, I thought that we should talk about the effects of patient motion. So the number one goal of radiation therapy we always want to make sure that patient is in a position that's reproducible. That's the number one goal. So therefore, by doing that, you also make sure that the treatment delivery dose, basically, you want to make it match the treatment planning system. So therefore, the effects that patient motion management have on that, the treatment dose planning system does not match the planning system dose. We can also compromise target coverage, and possibly we can increase the dose to the OARs. So those are the challenges that we deal with patient motion. So effects of patient motion, I thought this chart, this diagram helps a lot when we're looking at to understand what the GTV, CTV, and ITV looks like. So with your gross tumor volume, your GTV is usually visible tumor. Your clinical tumor volume, your CTV, is GTV plus possible non-visible subclinical disease. So you see that there. And then your ITV, your ITV is actually your significant patient motion present. It counts for that. It counts for the internal tumor motion. And then you have your PTV, your planning tumor volume. It consists of your ITV or your CTV plus margin, and also accounts for random and systematic variations of treatment delivery. So basically, the big takeaway from the slide is more motion means more tissue receiving the full prescription dose, basically. And in terms of RTs, when we're matching on the treatment units, PTV is one thing that, we always make sure that we turn on when we're matching on our imaging as well. So that's significant of that too. Zoom poll. So Claire,
all right, let me get this one.
See what the answer is here. So which diagram outlines a plan that accounts for motion? And the answer, yes, it's C. So another slide that we wanted to focus in on briefly was how does motion affects MD contouring and decision making? So basically, increasing the PTV margins may increase the radiation of typical surrounding structures, and it may limit the ability to escalate the dose safely. So CBCT, what we use for our imaging, it can detect like different alterations, tumor response, everyday tissue changes. So this I thought was a good slide to put in there. So when we're on the treatment unit, we can always see changes. We can see if the lung collapse, if it's filled with fluid, and of course those are the things that can potentially reduce your PTV margins, which of course you would escalate that to your MD and clinical team. So to start off, we're going to talk about the types of motion. We have your interfraction motion and your intrafraction motion. I also get these two confused, so I thought it was a great idea to how we broke this down in this presentation. So interfraction motion, So that definition of that is variation in your patient position from a day-to-day standpoint. So major sources, right? You have your translation, your rotation, and your position, weight loss or weight gain. As you know, we look for when we take our imaging, we look at that external contour, internal organ position. You know, you have your stomach, whether some you try to replicate that patients are possible empty stomach, bladder filling. You know, you drink certain ounces of water. So we can get that bowel out of the way. And then we also have bowel filling, which, you know, sometimes the MDs may request, you know, enema, and, you know, or even gas X to, you know, get rid of that gas. So these things are important and they do affect motion. So how do we mitigate the interfraction motion? Patient coaching, very important. We see this during simulation. We see this during treatment. We need to coach the patient. So basically the patient follows a pre-treatment protocol, so such as bowel, bladder, stomach preparations that we talk about. If it's the enema, is it drinking water, or is it some sort of empty stomach protocol that we need to do? So patient coaching is very important. So we also get mitigate this by mobilization, very important. How we immobilize the patient from simulation. So the first slide here, you can see that, you know, it's the 5-point mass. We want to make sure it's comfortable, reproducible. We want to ensure that, you know, patients in that position that emphasizes the chin and the mouth being closed, because those things, you know, can move. So the movable points we want to immobilize. That's the takeaway from here. Thorax, hand pulls can be up in the air, arms are raised in a tolerable position. You may give the patient some hand pulls to stabilize that position, you know, to get rid of any shaking or anything of that sort. For extremities, example may be knee positioning, and we put on something on the foot. And the big thing here is movable regions. You want to put, you know, try to get rid of that rotation on that foot area. Same thing with breasts. So we can see in the prone position, patients with the pendulous breast. This position can help basically control motion on when they're laying in this position. For the abdominal area, adding some sort of compression can reduce that abdominal motion. And also in the pelvis area, we see you add a knee cushion along with that pelvis immobilization to try to get rid of that movement as well. So mobilization is very important. So this actually starts from simulation, of course, like anything else simulation. So another way we can mitigate the interfraction motion is the imaging. So we do the image guided radiation therapy. So, you know, we have two types that we do on the treatment unit. We have the 2D and we have the 3D. So with our 2D, we're looking at X and Y couch translations. And the only thing we can basically see with that is our high density objects, bony anatomy, metal, you know, our hardware, and things like our fiducials and stuff like that. On the 3D, similar to CT scan, but we can get the X, Y, and now we have that Z couch translation coordinate. So possibilities, if we have any type of rotation or roll, we can see that. And of course, our internal organs are visible. You know, liver, any other type of soft tissue, we can see that on our 3D. So that's a great help. So another poll. So methods to improve accuracy in treatment delivery, accounting for interfraction variation, including the following, except. All right, so it was a tricky question, but it was some keywords. One of these answers are not right, but we're accounting for interfraction. We spoke about mobilization, we talked about the bowel prepping, we talked about the imaging. So respiratory gain we didn't talk about, but on the same token, from what we spoke about is these three were correct. This was not correct. And the key factor here was interfraction variation, basically.
So Trevin, can you just can you just highlight again what interfraction variation is?
Oh, interfraction, yes. So interfraction is our day-to-day. Let me go back to the slide. So interfraction is our variation in patient position from day to day. So going
from one fraction to the next fraction is interfraction, right? Got it.
And those are the things we talked about there. So it was a confusing question, but
that's a good question.
Yeah. So from interfraction, now we look at intrafraction motion. And now we'll talk about the motion during a treatment. So major sources for that can be your tongue, could be your larynx, can be your eye, heartbeat, respiration. So same thing again, patient coaching, very important. It's important that we tell the patient, have them understand the importance of not moving during treatment. As you all know, we work in very small millimeters. So this is a message that will keep consistent from simulation to even the treatment floor. So patient coaching. If on our head and neck cases, we'll typically use a white block along with the mask to help with the any movement in that area, especially around with the tongue. With the larynx, we'll tell the patients not to swallow. From simulation, when you're doing the scan, you'll tell your patients not to swallow. You do the scan. Some MDs that I've worked with during the actual course of treatment for the head and neck, so you'll tell the patient don't swallow when the beam's on as well too. So, and these are things like for us, the MD would indicate. Not all MDs do it. The eye positioning is good for us to coach the patient to look in a fixed direction, and that's to help with the movement of the eye. We all know it's pretty radio sensitive structure. So basically mitigate intrafraction motion, respiratory motion. Just wanted to break this down a little bit for you, right? So free breathing, that's one way. Patient breathes normal. We can add compression to reduce motion and also understand that the motion is accounted for in the planning via the ITV. Then we have DIBH, deep inspiration breath hold. With this, we all know that when the beam's on, patient's holding the breath and the radiation is being delivered. It keeps the lungs in the same position, and it requires 2 or 3 breaths on average, basically. And then with gating, that's free breathing, but the beam's only on when lungs in specific position during breathing cycles. It increases the treatment length. Respiratory motion needs some sort of characterization, typically during SIM and monitoring during treatment. We're going to go into all these. Intrafraction motion, we also, simulation is a big one. So a lot of our cases, we do 4D CTs. So we use it for gating. We use it for scanner, captures breathing cycle each bed position. So with the 4D CT, at simulation, you'll see that phase bending thing where it's from 0 to like 90%, where they can capture the tumor at different levels of the breathing cycle. It's a very slow scan. You need a reflector box and a camera, and it reconstructs sets at each phase of breathing cycle, that's 0 to 90%, which I was talking about. So intrafraction motion, DIBH, and gating patient screening. So we have patient education. Do the patient understand the breathing instructions? So it's important for you to have patient education. And for some of us, some MDs like to do it at their console and also give patients. Sorry. Like to give patients instructions at the time of consult to help with this breathing instructions. I think I have something on here that we'll go over to. Patient screening, does the patient have a regular breathing pattern?
Sorry,
No problem. Patient screening is a big thing. I just wanted just a quick example for like our lung cases that we try to we try to assess them to see, or our DIBH case, we try to assess to see if the patient can tolerate the time of the SIM. So we try to prep ahead. So what we'll do is we'll take like 3 DIBH scan, 1 free breathing, 1 4D. And just in case the patient cannot tolerate DIBH on the machine, they're able to go free breathing or gating, basically free breathing because of that gating scan on the machine. So we try to assess everything at the time of SIM. So intrafraction motion simulation. So you need free breathing scan. That's a slow 3D CT or 4D CT. We can do gating, 4D CT, 3D CT free breathing. We can do 3D CT expiration and inspiration breath hold. And also looks like PET sometimes can be a very valuable option. DIBH, 3D CT free breathing, optional, and 3D CT inspiration breath hold for simulation. So this is a quick video of a patient just free breathing. So I'll go ahead and play the video here. we can see that the ITV margin encompasses the entire motion, basically based on a 40 CT, or basically a 3D scan with larger margins. May consider adding compression to this. Add compression basically to reduce the motion, and that will have more tissue treated in that way. For these cases in particular, before the simulation for us, if we're going to use compression, we'll take it to the treatment machine. We'll do a fluoro scan first. We make sure we have tumor within like 1 millimeter, and the doctor will come at the treatment machine with the and we'll determine what level of compression is needed if this was compression. So interfraction motions for simulation. So we're going to review the techniques along with the gating boxes here. So the interfraction motion for simulation. So the marker box in the IR camera for the lung motion detection, that's always present with these. We want to place the box in a good in and out breathing trace position. We have to establish between chest versus belly breathers. And the biggest thing is we want to have the identical location in sim and in treatment. So we want to make sure that we're indicating on our simulation document clearly to the treatment therapist where this gating box is going. Ideally, rule of thumb, we normally have anywhere in between the xiphoid process and the umbilicus, basically, for the gating box. Typically, we like to go up on the xiphoid process, but if there's no motion there, then we have that leeway to put it somewhere, basically in between somewhere. We also want to label, however you can replicate this back to the treatment floor. If it's a cast being used, you want to label the cast lines where this gating box is. Now, the challenges is if you have RPM versus RGSC, so you'll have two different gating boxes. So with that being said, this is the difference between the two boxes, but this is how they can be the same. So you want to establish some sort of block placement rules. So like I said, you want to place it on a flat region. You want to have it on a stable point relative to the xiphoid process. If the patient anatomy is concave, sometimes we do see that here. Then you have the adjustment to bring it down somewhere in between this area of the xiphoid and the umbilicus. So the rule of thumb, 2/3 of the way superior from the umbilicus to the xiphoid process. So this is an example where I found, which is not an ideal placement, either it's this because of how it's tipping. So you won't get a proper reading, but flat regions, what we need. Here's where I have we'll place the cast lines where this, basically where the middle point is, we'll place a cast line so the treatment therapist is able to replicate it. And this is the, like I said, if you have RPM in your sim and then you're treating on the RGSC, that's the comparison of the two. So what we will normally do in this case, if we have the two different boxes being used, we'll just mark the inferior portion of this box, and that will coincide with the middle parts to this box here. So basically, so this is the setup for simulation. This looks like an RPM setup. So with this, we want to make sure the camera's on the couch for the same distance and the box is visible throughout the whole scan. If the box is not visible, and of course you check that before you leave the room. If you don't, then when you go over to check your trace, you're gonna it's not going to be an accurate trace. It's probably not going to read properly. So you want to make sure one therapist is in the room fixing the box, the other one's on the computer side just checking and going over just to see if it's reading correctly without anything blocking the box. So interfraction motion for respiratory gating software. So the most important thing here, you record the motion of the marker box. But the biggest thing from here is the camera captures the reflectors. And also at this point, we will look at the summary between the respiratory motion and then manually the boundaries are being set and the tolerance is being made here on this part of the computer. When we talked about interfraction motion, DIBH coaching, this is something we touched on earlier. This is basically this is what we gave our therapists as a guide, and also some institutions will give their patients also too, so they can understand how they should be laying down in reference to the couch. You want to lie in the back of the arms above the head with rolls of the knees. This one here is maybe for like a breast patient or possibly a GI patient too. But this one's more mainly for breast patient because of the angle that this patient's on. But this is just an example. So you instruct the patient to breathe for DIBH. You'll ask the patient to breathe, take a few normal breaths, and then we'll tell them how to take deep breaths in and how to practice. Basically, you're going to take a deep breath through your nose and then fill the chest and stomach. Breathe out slowly, return to that normal position. We kind of try to repeat that a few times, 3 to 4 times. And that's how we know we'll have a real trace. And we also know that the patient can tolerate that too, which is the most important part. So it's important for them not to arch their backs. A lot of patients like to arch their backs, and when they're not tense, it makes them more tense, and that can give you invalid readings. If the patient is moving off the table, ask patient to breathe deeper into the stomach. So those are important things. And sometimes patients like to cross their legs too, or tell them not to cross their legs. So these things, at the end of the day, the main takeaway, this patient positioning impacts it. Also, your coaching impacts this kind of delivery too. So that's something we stress in simulation. So this is basically the setup here. You normally have some sort of IR camera. You'll see the box here and the reflector box here, and that's what reads in this scenario. And depending where you are, either the treatment floor or even the sim, it's almost the same setup. So here, interfraction motion, DIBH treatments. DIBH increases chest distance from heart to lower the cardiac toxicity. So this is a perfect example of what we do. Just an example, in simulation, some BMDs like to basically assess if a patient can handle DIBH, but most of our patients that are left-sided DIBH breasts, they typically are DIBH, but they like to still check. So what you do is you'll probably take a slice at the thickest part of the heart, maybe a 5mm cut, and then we'll go ahead and we'll look at this here. So you see in the free breathing, the heart's here, and then when the patient takes the breath in, you see how that decreases a whole lot. So that really helps. So image 1 depicts a patient with blank, and image 2 depicts a patient with blank.
Okay, so I've launched the poll. Just while that poll's running, Trevin, there's been a question which is a really good question. So one of our participants wants to know what's actually the reason behind a patient arching their back during a DIBH treatment.
Okay. It's just not, I won't even single out DIBH treatments. I'll just single out patient in general. Patient can be nervous. Patient can be, they can be nervous and stressed at the time of sim, or even on the treatment floor, not understanding what they're going to get into. So typically, if you're tense, they're going to arch their back. So you want to instruct the patient not to arch the back. So kind of tell them just to relax, typically. So it's not like related to like just DIBH, but I think just for simulation and whole patients typically tend to do that when they're like, tense.
Yeah, look, can I jump in and add a little bit there, Trevin? I guess just from what I've seen in my department with DIBH patients, sometimes if you're coaching a DIBH patient, you're saying, breathe in a little bit more, breathe in a little bit more. If they feel like they can't, what they'll do is they'll start to arch their back so that they'll bring the box up into the right place. So sometimes patients will arch their back to get the box in the right place for the therapist during treatment as well, if they feel like they can't breathe in any more than that as well. So that's another reason that patients arch their back. They're just trying to make you guys happy. Get the box in the right spot.
On that point too, when they use the VCDs, the screens that the patient can see how they're breathing too, I think that kind of encourages them to arch their back too, because like you said, they can see where they're supposed to be in terms of that trace. So they know they have to get to a certain point. So they probably try to cheat it a little bit. So yes, same thing. I agree.
Yeah, it's cheating.
Yeah.
All right, everyone keep their poll responses coming in. We've got about half of you. I know some of you are typing in the chat, which is fine. If you can't see the box, obviously, I think if you're watching on your phone, sometimes it doesn't pop up. If you can see the box, better to fill it in on the actual poll. I think A and B seem to be the ones that are what people are thinking about at this point. I'll give it another few seconds. Just while waiting, in the chat, I'll pop up the link for the attendance again, and just make sure if you do have questions to pop them in the chat as well so that Trevin can answer them for you. I'm not sure how many of you are actually doing any motion management or 4D CTs, or doing DIBH treatments. I'll give it a little bit longer. So just while poll's still going, Trevin, there's another question. Is it possible for us to detect patients arching their backs on a simulation image? So I guess during the CT.
I think if it's like really like, ideally, what the standard looks like. And I think you'll be able to catch something like that. Like, oh, this looks a little off, and then maybe you'll dig into it. I think it'll be a challenge to catch that.
For sure.
Yeah, I think it'll be a challenge to catch that. I think you'll probably catch it more in the breathing, though, not the imaging, in the breathing, because you'll notice, like, wait a minute, how come the trace looks like this here versus that? So maybe you'll catch it there during your practice breaths, especially because we do like 3 to 4 practice breaths.
I think I'd arch my back if I was a patient. I think I just naturally would. I don't know why. I just feel like I would. I'd want to be hitting that mark every time, even if I couldn't breathe that far.
I'll be the worst patient every time. I mean,
yeah, for sure.
Anything that we'll get annoyed off the treatment unit and sim unit, I'll
All right, let me end the poll now. Thanks for those that participated. And I'll just share the results with you.
All right, so image 1 depicts a patient with blank, image 2 depicts a patient with. So image 1 depicts a patient with breath hold, and image 2 depicts without breath hold. So as we can see here, we're looking at the heart on that chest wall, and we can see the difference, the clear difference between the two.
Perfect. Sorry, just before you go next, there's just been one more question about everyone's quite interested in the patients that arch their back. Yeah. And so Victor's asking, what's the implication if a patient arches their back?
I don't think, but when the patient arched your back, like I said, it's more related to when you do your treatment breaths. You'll notice it during the troubleshooting process, when you notice that the patient's something's off with them getting to their trace. And but in terms of implication, it will be more so related to the trace, right? Then they won't be able to tolerate the DIBH if it's the reason why they're arching the back, so they can't just do it normally. So if you do your breath hold traces to see 1, 2, and 3, hey, something's wrong. So it's just like a red flag. And at that point, you probably escalate it to like a physics team to see if there's anything else that we can do. Yeah,
absolutely. And obviously, if someone's arching their back during treatment, it means that they're not in the correct position for treatment as well. And just, sorry, one more question. Trevin, they're all coming in now. So what are the difficulties arising in DIBH of the liver, particularly?
The DIBH of the liver? Oh, we'll get to that, but the issues with DIBH for the liver, I would say more so is the gate. When we're doing breast treatments, I think we're doing like a 0.5 millimeters, but when we do like the GI cases, we're doing like a 0.3 millimeters. So that gate is extremely small. So the biggest challenges with the GI cases we see is getting patients to stay in that gate, that 0.3 gate. That's one of the biggest challenges that we see. So like, so if they're arching their back and doing all these other different things, if you can't get it in a 0.5, then a 0.3 is like, you know, that's tough too for them. That makes sense.
All right. Thank you. That's perfect.
No problem. Thank you, guys. All right, so back to what we were saying. So when we're doing the DIBH, we're looking at the trace, and this is the ideal trace, right? You want a patient to breathe right into that gate, they'll drop off, we'll have them hold, and then they'll release back off to what they call the true zero. So at the treatment level, the ideal gate, right? So the breath hold can be done at inspiration. So for breast, typically, and then it can be done in expiration, and that's for our pancreas, liver, esophagus. And that's what will make this more stable and consistent. The MD will choose to indicate on the prescription, probably from some institutions, they'll indicate where they want this breath hold to take place. And for our ideal gates. So when should you take the image? When should the image be taken? So basically, what would it mean for treatments if your IGRT image was taken at one point versus the other? So when we're looking at point A, right, we can see that if you take your image there, you'll be chasing the position, basically, and I'm talking about when you're doing your match. You will have basically taken the image and adjusted the couch vertical, but then most of the treatment will be at a different position, right? And then image B, this is kind of like better because you'll have that 1 second delay for amplitude breath hold. And this kind of much more represents the position for treatment, and it's more consistent. Sometimes you take your images and you see maybe your spine and your anterior chest wall, you're chasing that, and it's one on, the one is off. And that's one of the things you see. You put the spine on, but then you see your anterior chest wall is completely off. And that's a big indication that, yeah, maybe something's a little different, something's wrong here. Another time we see this is when you're doing the breast cases, DIBH, with the hearts. You can see that the heart is like completely off. And sometimes that's like an indication for us too, like, hey, maybe something's on. And then, you know, sometimes some patients you may need to put that delay on for. And that's set on, you can set that on the true beams, right on the console area. So continue this on DIBH treatment. Patient needs to be, so if you look at this gate here, so now you have a non-ideal gate, right? Patient needs coaching to do a smaller breath hold, or it's not a candidate since they leak air. So that is something to pay attention to. And like I said, the institution that we work at, one thing we started to do now, for our lung cases, we started to do 1 free breathing scan, 3 DIBH scan, and 1 4D. Just in case this patient's not a good candidate, then we know we can, the MDs, the physicists have that, so they can plan something gating or something of that sort. But on the same token, the patients, they're holding their breath 3 to 4 times, and that's when you know if they're a candidate or not, because they're going to have to do this 15 fractions, 20 something fractions, 5 fractions, whatever so be the case. So simulation is a good place to know. But on the same token, with the non-ideal gates, for this case in particular, the patient that basically held their breath too deeply, so the beam does not deliver, right? We would coach the patient to breathe in less deeply. And we also notice that the patient leaks air. This is common and should be evaluated at simulation. If the patient leaks too much air, then they may not be a good candidate, or they can be coached, like we said. So this slide.
Sorry, Trevin, just while I've got to pause, there's been quite a few questions coming through in the chat. First question is, as far as DIBH is concerned, will the irradiated volume for the lung increase, or will it be the same without DIBH?
So for that, for me, that should be like on the planning side. I mean,
Yeah. So I mean, I typed in the chat. It's roughly the same.
okay.
Like the volume of lung irradiated is roughly the same. It's just the volume of heart is a lot less if they have DIBH, because your baseline should still really be passing through the same volume of lung, whether it's inflated or not. And then another question, the gating window level, like what is that, and I guess how is it determined?
Gating, so like I said, from simulation, some institutions have set, so the gating, so basically the distance between here and here would always basically be the same. So for example, if I'm doing a breast case, I'm doing a 0.5 millimeters, no matter how I move this up and down, it's going to be 0.5 millimeters. GIs, like we said, in lungs, 0.3, no matter how I move this up and down, the distance between this is 0.3. Those are set standards that our institution has. But on the same token, when you're doing this part in simulation where you have the patient hold their breath and they're holding their breath here, this consistent breath hold can probably even be down here. So you'll move this gate here, basically, and that's how it's established. So this doesn't change, but where the patient's peak is changes for every, it can be different for every patient. They may not be 1.3 to 1.6 or 1 to 1.3. They may not be there. So that's why you can move this at some point in the simulation. So that established during the sim, and you might have standards at your simulation for that.
Okay,
Yeah.
so you're saying like the window itself can move up and down depending on how full a patient can fill their lungs, meaning how far the block will move on their chest. But the width of the window is fixed.
It's fixed, yes.
Yeah, perfect. Okay, so a couple more questions if you're okay with that.
Yeah,
so how can the position of a patient who presents with a persistent cough be maintained at both simulation and treatment?
Well, if it's a persistent cough, sometimes the MDs would let us know, and sometimes there's medication they can have for that. But if it's a persistent cough, then it's not, it may not be a candidate for DIBH. And that's something, of course, we don't determine, MDs will determine that. Because it's no way they're holding their breath, they're going to keep coughing. The trace will not, you won't get an ideal trace like this. You'll get a irregular trace, and that's huge.
Yeah, so you just wouldn't be able to do DIBH with that patient. And then there's a similar question about if a patient coughed during treatment while they were doing breath hold.
If a patient coughed during treatment, the beam shuts off.
Yeah.
The beam shuts off. That's the best part about the breath hold. And that's the same thing you tell your patients all the time. And of course, you don't want to always tell them like, hey, you can just jump out the gate all the time because you'd rather them stay in, but we'll let them know it's okay. Like, if you come out, the beam will shut off. So that's fine.
Perfect. Couple more questions.
Sure.
So how do you compensate for the movement distance during DIBH treatment proper? So they said inspiration involves a chest movement upwards and forwards, and expiration involves a movement downwards and inwards. So I guess they're sort of saying, the block is really measuring in one dimension rather than in in two dimensions that your chest would normally move. So is there any way we can compensate for that, or we're really one dimension?
Well, outside of that, I don't think, right?
Yeah, look, I think from a physics perspective, we're putting an external marker on top of the chest to mimic what we would think the lung would be doing inside the chest. So whether the motion is not quite straight kind of ant post up and down, it's still a surrogate for what's actually happening inside the patient themselves. So you can't really compensate for all of it. It's really just an approximation for how much lung volume they may have based on an post movement of the chest wall. I guess that would be my interpretation of that question. So if we move, so there's just 2 more questions and then I'll let you get back to the slides, Trevin.
Yeah, it's fine.
So what is what PTV margin would you use for DIBH versus free breathing for a lung carcinoma?
Which PTV will we use? Oh, no, it won't be any different. We'll always just use whatever, just PTV. Like if you're talking in reference to like ITV or anything that we do see on the planning and stuff, but we still use PTV. Yeah, it's not like distinction.
Okay, perfect. And then just one more question: is DIBH essential for all patients, irrespective of their health conditions?
Oh, that's a good one, because sometimes we'll get like patients that are like 90 and like, why are we doing this type thing? So I think
it's a case by case, really, isn't it?
Case by case, if a patient can tolerate it, but most of the time, yes, for us it's standard, because we did some 90-something-year-old patients, so like why they're doing this type thing. It's like a standard, and it's it's a lot of studies behind it where they believe what MDs believe in. So yeah, for every patient that it's a standard for certain cases. But if they can't tolerate it and it's not ideal, they definitely would say, hey, let's not deal with this. And it's other techniques that you can possibly use outside of the breath hold that we'll go over.
Perfect. All right. Thank you, Trevin. I'll let you get back to your slides.
Thank you, guys. All right. So this was an image. I think this is what, so this is like, in this image, you can notice that the spine and the sternum are aligned correctly. The patient's taking a perfect breath hold. In the event the patient did not take a perfect breath hold, and let's say we didn't put that delay on, the spine will be on, but the sternum would not match. Probably, this would have been way off. You can tell. You can tell how the patient. So, another poll image that the lateral ISO showed the sternum was in the position of the yellow line. What should we do? Right, so basically we imaged. Imagine that the lateral ISO shown, the sternum was in the position of the yellow line. What should we do? The answer is B, ask the patient to do a smaller breath hold. So that's what we reviewed earlier. Depending where the patient's in that gait, we would show and exemplify that, basically. So a smaller breath hold would do the trick for here. And this is one of those cases we're talking about. The sternum comes all the way out. So basically, the sternum does not match the spine. So how do we get that where it needs to be? And all right, so intrafraction motion with the gating treatment. We're also going to go through phase gating and amplitude gating. So with phase gating, it's predictive. So phase is a particular part of the breathing cycle. It predicts based on calculations from a few breathing cycles. Beam on is zeroing only on the selected phase of the breathing cycle. So basically what you'll have here is a dial that is set to you have your dial here, which is the breathing cycle, full inhale to exhale and back to full inhale, right? And then the bar is the range of the gating cycle graph, basically. So just an overview of the software for this particular phase gating. So this is an example for phase gating. So basically in phase gating, the radiation beam is activated only in a certain phase of the respiratory cycle. In the amplitude gating, the radiation beam is activated whenever certain amplitude values reach, regardless of the phase in the patient's respiratory cycle. So you can see here, breathing, the correlation between breathing in and out, where the phase cycle is, the beam's on there, but off there, on there, off there in that cycle. So that's the correlation to that there. So with respiratory gating, amplitude gating uses the thresholds. So basically we set the manually limits to amplitude to keep close to inhale or exhale lines of the threshold. Amplitude gating uses set thresholds to indicate when to turn the beam on and off. So basically thresholds are set, as you can see there. You place threshold limits to relative to the amplitude, and you beam on when the breathing motion's in the desired position. So this is an example right here of an amplitude gating. So you see the full inspiration, the upper threshold, the lower threshold, and where the beam on typically is with this. So basically, patients just breathing, and it's calculating cycles and determining when to beam on and beam off, basically. So basically, beam off during deep inhale, and it beams up during deep inhale or exhale, basically. So this is an example of the trace here. So whenever it gets too deep, another way, basically, so when it gets to exclude extremes, basically, when you get to the extremes, it would beam off in this particular cases. So this is a video here of what an example of, this is an amplitude gating in the case of fiducial markers. And with this here, you see the KVs during the treatment. The gates on position, the gate turns on in positions of the fiducials. So I don't know if you guys can see the right there. Every time it goes in position of the fiducial, you see that it's turning on right there. So the zoom pull again. What would happen to the breathing trace if the treatment couch moved vertically higher by 0.5 cm after matching?
Okay, pulse open. There's one question. I think it's just to me, but Trevin, you could probably answer it as well. What do you usually use, phase gating or amplitude gating in your department?
Yeah, we use amplitude. We don't use phase gating.
Mm-hmm.
We don't use phase gating.
Yeah, we're the same. Yeah.
So I honestly never seen phase gating in practice. I mean, outside of talking to like our physics team about it, just in correlation to other things that we use.
Yeah, for sure. Yeah, I don't think I know any departments that use the phase gating. I think because we're worried about position,
Yeah.
and phase doesn't necessarily correlate with position, so amplitude tends to work better for us. Okay, everyone keep their responses coming in. Beautiful. Oh, it's almost split. 30, 1/3 each. Sometimes it's hard to like mentally picture what would happen in all of these cases. So just have a think about the treatment couch was vertically higher. So then what would it look like on the patient's trace? So Victor's just asked a question about why phase gating is not really in use. Victor, I guess from my perspective as a physicist, what we're interested in is patient position. And often if you're just looking at the phase that the patient's in, you're not necessarily looking at the position that the patient is in during the different phases. So I think we just feel more comfortable using the amplitude gating just because it's an actual space in like it's not a time-based thing, it's a distance-based thing, I suppose. But Trevin, your department may have other reasons that they don't use phase gating. Trevin, there's one question. How would you do a cone beam CT with the breath hold?
Okay, so depends what you're using too. If you're using the true beams versus just the Linacs, they're slightly different, but all in all, it's the same concept. So it's a settings on the true beam. If you're using true beam, you can set the true beam to only take the image when you're in the gate. So in the case of the CBCT, you tell the patient, go ahead, hold your breath. Normally, if it's a full CBCT, depending on the gate size, it can be very challenging. But once they're in that gate threshold, just like treatment, the beam turns on for a CBCT. If it's a full scan, then it can be challenging because they would have to hold their breath for the full arc. Sometimes you may need to give them breaks in between. But yeah, it's very similar to just treating. Once they're in that gate, the CBCT goes off and they're holding while you're imaging.
Mm-hmm. Perfect. Okay, I will end the poll. Share the results. So it looks like we've got a fair split there, Trevin.
Split, yeah, it's definitely a tricky one. So let's see. So what would happen to the breathing trace if the treatment couch moved vertically higher by 0.5 after image matching? The answer will be B. The patient's breath trace would go higher by 0.5, basically. Which makes sense. A lot of the times too, when you move the couch, let's say you do your shifts anyway, this is another important reason why the trace has to retract again every time, because of this would happen. So if you do your shift after this and then you go in again, if it doesn't retract, then this will be inaccurate. I know some systems you may have to do it manually. TrueBeam does it automatically, but some systems you have to do it manually, and this is the reason why.
Just before the next slide, there's just a really good question. So when you're using amplitude gating, when does the beam turn on? So do you use like the absolute peak amplitude, or do you use like halfway through, so the average amplitude for the beam to turn on? Is it always the peak, or is it always?
So like I think we discussed, so when you're coaching the patient, the beam doesn't automatically turns on. For the imaging, it automatically turns on. But for the KVs, it automatically turns on after you hit it. But for the treatment, you would coach the patient into a relatively good area, and you can turn the beam on there. So you're basically deciding when that beam is going to go on in terms of where the trace is, basically. Does that make sense? Yes.
Yeah. Perfect. Thank you.
Hello. Hello.
Yeah, Chris, was that your question? Did Trevin answer that for you?
Not exactly. So that means, are you saying it is not an automatic turning on?
Yeah.
Or is it a manual turning on?
It's not like a manual turn on, but you can decide when it turns on. So for example, like a true beam, you can hit the beam on button, but if you're outside the gate, it's not going to turn on. As soon as you drop in the gate, it turns on. It's just hard for you. Like you can be at that peak, but then you can start dropping down. I've seen patients where they're at that peak and then they're starting leveling off in treatment, but they're inside that gate. You know what I mean? So it's not something that you can really determine like you can with the imaging, because the imaging is just like one plane that you're doing in terms of the trace. But with the actual treatment, you know, it's going on, so you can do that too, you know. But the story is, once you're inside that gate, it's going to turn on. I mean,
yeah, you tend to place that gate in a part of the cycle that would hold it the longest. So if you have a patient that breathes in and tends to breathe in, hold their breath, and then exhale quickly, you'd put your gait in that period where there was, the least amount of motion. So that might be on the inhale. Whereas you might have another patient, when they exhale, they actually exhale and just hold their breath, like exhale and don't breathe in for a while. So at that point, you'd put your gait at the bottom of their trace. So you often position it based on an individual's cycle as well. So,
Okay, so you actually control it by observation.
Yeah, because for example, sometimes you have patients that's always going way up higher over this gate. And I know that they're holding, and I know they tend to go and they tend to drop. So we'll trick it a little bit. We'll have them breathe in, breathe in, breathe in, have them hold right here, because I know they're gonna drop a little bit and then beam on right there. So it's kind of like, that's all part of the coaching. First day, you coach the patient and you get an idea of how that patient breathes too, in a way. Yeah, makes sense. Yeah.
Okay, thank you very much.
No problem. Good question. Thank you.
Just one more question, Trevin, sorry. If a patient is a belly breather, this is a really good question. If the patient is a belly breather, does the amplitude really reflect the change in lung volume? That's like a whole research project right there, that question.
Belly breathing.
I think, again, from a physics perspective, you're doing the best you can. Like if you do have a belly breather patient, it's probably the amplitude of the motion probably won't truly reflect the same change in the lung volume, but it will reflect somewhat. So I don't think it will be a true reflection of absolute volume change, but it will be a reflection that the lung volume is changing. So the point of part of this is to ensure that at the same lung volume, you're doing your treatment. So I think it's a fair assessment, but it won't be an exact reflection between belly breathing and lung volume, but it'll be close.
And during the coach process and simulation, when we're doing this, we're telling the patient, like, you give them that coach instruction how to breathe too, belly versus chest too, but that's just so you can get an accurate trace on basically too, from the RTT's perspective. So we also have intrafraction motion, we have gating. And with this is, you have the 2D or 3D CT scan and you apply shifts and you acquire your respiratory motion. So your respiratory motion with these gating cases, so back to that question where patients can't hold their breath, what happens, sometimes they'll offer this respiratory gating. And what happens is the beam will just turn on. Again, the beam turns on when it's in the gate, but the patient's like free breathing, basically. And could be a nightmare sometimes in terms of how thick the gate is. So if like we talked about the GI cases, if it's a 0.3 gate and that patient is just free breathing in there, you can imagine how long that treatment can take, because it's every time they get there, they breathe out, breathe in, breathe out. And then sometimes the machine can coach the patient, breathe out, breathe in, breathe out, breathe in, breathe out. So that's an option too. And this is basically the workflow for the respiratory motion too. So that's an option. Another option is for intrafraction motion is surface guided radiation, SGRT. I can go on for hours on this one, but we'll just keep it. So what it is basically uses a 3D camera system to track the body surface in real time. It may be used to help position the patient accurately before radiation, and also it ensures to keep the patient in the same position for treatment. So we can also do DIBH with this too. As you can see, the trace and accuracy here. The reason why it's a big thing, because you're not using any type of radiation to track the patient. It's just some infrared lighting that you're using in the rooms, and you're able to track the patient's Burt long lat, yaw, roll, pitch, And then some institutions, as this is like, we use it a lot for our brain cases, and also our breast cases. You can also go tattooless with this too. So this is why it's such a bigger intervention. You don't have to give tattoos. But on the DIBH side, it's the same concept. We don't do anything typically different. You still tell the patient, breathe in, hold their breath, and then you're paying attention also to your vert, long, lat, and all your parameters. The key is this is matching from the first day. You'll have a reference, and basically you'll also take a treatment image to make sure that it's aligned the same way. The difference that you're getting is the reference from the day of, basically. And that's the numbers you have. Some institutions may give you some sort of parameters, some guidelines, some numbers. Hey, you need to stay in a certain gait range. If you pop out of here and make them red, and you have to beam off because you know that you're outside of tolerance, basically. And that's the indicator. That's GRT. But like I said, this is we can have a whole discussion on this one. But this is also another way where interfraction motion, another way for interfraction motion and how to mitigate it. So basically takeaway points in general for this, you want to be aware of daily organ position. The ITV margins used when interfraction motion is present. Your immobilization to reduce interfraction motion. We use IGRT in motion management devices, and we beam on at particular positions of motion, which all those techniques that we just went over shown, right? And that's all I had. And next week will be imaging technology and radiotherapy. Any other questions?
Excellent. Thank you, Trevin. Couple of questions just from the chat. So are there times when you experience differing timing in one complete cycle during the DIBH treatment?
Differing timing in one DIBH cycle, are we so just to clarify, are we talking about so we're treating one field, or we're just talking about that, like we're in that one field of treatment, we see different timings there we're talking about?
No. What I mean is, you know, as the cycle goes on, you have a trough, you have a crest. That's one complete cycle. So what I'm saying is, from the position of the zero line of coming up to a crest and then going down to a trough to get a complete cycle, is it the same along the line of one complete treatment for DIBH?
In general, it's about the same, because like I said, you can if you use the TrueBeam will show you that simulation where they were, kind of thing, and then you can match it. And when we normally turn those two on, it looks pretty much close. So yes, they're usually in the same, and that's the big reason why you coach in the beginning, so you can establish that it would always be that same. Does that make sense?
Oh yes, thank you very much. And in instances where maybe all the cycles are averagely the same, but one tends to be longer for that deep red hole, how do you even it out?
How do you even it out? I don't think it's, I mean, like I said, you never really see that. Like, let's say you're doing your arc treatments. Normally your arcs are all about the same, around the same time. The only difference is when you go from, let's say you had to take a CBCT full arc on that patient, then yes, you do see those challenges when you have to take a full CBCT scan. In that case, you will, if it's 100, you're doing the whole spin, you probably stop halfway, give the patient a break, and then continue the other. So you go from 180 to 0, and then the other side, by 0, you take a break and then go again. And that way you can kind of like establish that you are doing the same. Because after a while, if the patient starts to strain, then they'll be outside of that. So does that make sense? Or?
Yes, thank you very much. Thank you
treatment,
very much.
I don't think we see that variation during treatment.
Okay.
Because you're coaching. So you're basically in control of that as the RTT, because you're coaching the patient. And that's why we stress coaching.
Okay, but are there in instances where a patient just suddenly fails in cooperating, what do? You stop the treatment?
Yes, so patient fails, of course, you have your escalation process, you have your MDs, you have your physicists, you have to talk with them. But like I said, with our institution, let's say for our lung and GI cases, so certain steps that you need to take. We also have standards on what to do if a patient cannot hold their breath, right? So a couple things we can do. But the first thing that we do is we simulate this patient with 3 DIBH scans, 1 free breathing, 1 4D CT, just in case we have to treat this patient gating free breathing. Let's say in the event they get to the machine and you want to really do DIBH, things that you can possibly do. You can move the gate. You can move that gate lower. You can move it a little higher so that the patient can think. But what we do, we have certain steps in place where we'll probably take a fluoro first, just to see how's that in relation to the tumor. We'll establish a new gate at the treatment machine. We'll let the doctor know and physics know, they give us an okay. And then from there, that'll be our new standard. Next treatment, we'll go ahead and we'll treat that. So it happens. It definitely happens. So, but we have processes in place where we can ensure to put that patient in an appropriate gait that doesn't impact their, treatment. Does that make sense?
Thank you. Yeah, it does. Thank you very much.
Great questions, Chris. Yeah, Trevin, if you've just got time, there's just a couple more questions, which are really interesting.
Yeah.
What's the ratio of patients that you might treat with DIBH on a single day? And also, what's the difference in treatment time for patients that have DIBH versus patients that don't have DIBH?
Okay, so our center, we're very big. We're a total of 8 sites, but my center where I work at the main campus, we see over a total about 900 patients total, because we have 10 LINAC machines. So I would say a good 40% of that's lung cases. So it's a pretty big number. In terms of treatment times, it doesn't change. Our treatment times are normally the same. We put patients in a 20-minute time slot, setup days 30, but treatment times are 20-minute time slots. However, if they are, they're normally 20-minute time slots for the regular ones that are in 0.5 gates. If it's a 0.3 gate, like I said, the GI cases, we'll probably give them 30-minute treatment times. The RTTs will assess, hey, we may need 40 minutes, we may need an hour for this, and then we'll give them appropriately those times. But for the most part, we can get them in the same time slots we get in any other standard treatments. Does that make sense?
Perfect. Thank you. Question on SGRT. So does SGRT with video technology exclude other imaging?
No, remember with the video technology, SGRT is just the infrared. So we're not doing any like imaging on that. But I can only talk for my institution, but I'm not sure. Do they have other? Maybe they do, but yeah, it's just outside of the video surface. It's not anything else. That the video is like the only thing you can actually see things outside the video surface. You're not getting any other detail, basically.
So would you do, say, like a cone beam CT on that patient if they're using SGRT, or does the SGRT negate the need to do cone beams or port films?
No. For a lot of cases, the SGRT is either for the DIBH and perfect example. Our SRS brain cases, yes, we use the Align-RT in conjunction with the CBCT. So the Align-RT gives us what we need for parameters, where we need to stay in terms of movement, because that just focuses basically on movement. And then we still need the CBCT so the doctors can assess the PTV, the margin, the areas, and everything that's needed. So Align-RT for us is used in conjunction. It's not just a standard.
Great answer. And one last question, I think, unless anyone's going to type any more in. So if the motion management system fails during the course of treatment, do you still give them treatment, or is there any other way that you could deliver the treatment if the motion management system isn't working?
So in the past, I would say no, just general answer. We won't do anything else if the DIBH because you may need a replan or something. But like I said, we have that data available to the MDs already, because we do the 4D CT just in case DIBH doesn't work. Then you can probably go gating. It depends if that plan is ready. But for the most thing, if it fails, then it's probably no. Probably the next day the patient will come back. We'll have a solution, and then we'll be able to treat, most likely, gating. And that's just a free breathing to go into the gate, and then we can treat like that.
Some final questions coming through, Trevin. Thank you for your time. So is DIBH specifically for chest wall treatments only, or are there other sites where you can use DIBH?
Other sites, so just a general overview, we use it for lung, we use it for breast, and we also use it for GI cases as well. So our liver cases get it too. So that not necessarily chest wall, right? But it's definitely a little lower. So that's an example of other cases we do use it for too. Perfect.
So if someone was in a radiotherapy center that didn't have the cameras or didn't have cone beam CT, can the RTTs do a blind breath hold for a left breast treatment?
We would never do a blind breath hold treatment. I can only imagine the implications on that. We did something like that. No, we would never do that. We would never do a blind breath hold. Everything has to be planned in that position. And then you're doing simulation has to be verified on the treatment floor. Because remember, during your radiation treatments, you need that DRR from simulation anyway, as RTTs. The answer to that.
Absolutely. Yeah, it's much safer if you don't have the equipment to do it properly. It's much safer if you just have a free breathing patient, because the risk of doing it blind is you are totally missing the target or irradiating more lung than you need to as well. So it wouldn't be safe to do it without the correct equipment. So there's a question: can abdominal compression with shallow breathing be used for a breast case?
We never use abdominal compression for any breast cases. I can't really speak on that.
No, we've given up abdominal compression altogether in our department, and certainly we wouldn't use it for a breast, because the abdomen and the breast are two totally different kind of areas. So we used to use abdominal compression for liver and things like that, but we'd never use it for breast.
So
good question.
We use it for, like you said, liver. We use it for the abdominal cases, but we don't use it for breast.
Yeah. And just one more quick question: does the coaching happen every day of treatment, or is it something that you do at simulation and then?
So we just had we called it a re-education, where we established guidelines for the RTTs so that their coaching, block placement, and everything's, but coaching, which is a big one, we went over the language, how the patient should be taught, and that should be done every single day. We coach the patient every day from simulation, and the language is consistent to the treatment floor. So little things like, hey, you tell the patient you want to take a breath in, but you also want to remind them you want to take a comfortable breath in, because if they're taking like this big breath, they can overshoot that gate, and they think like the more they take in, the better for them. But no, you want to tell them to take a comfortable breath in, so that's easy to reproduce. And those are things that you have to remind them on the first day, especially, and every day. Just tell them, hey, you have to coach them through. So that whole procedure goes as far as you take it, because you're coaching them every day. And it doesn't have to be the big speech every day, but you're also letting them know, hey, take a breath in. You want to tell them, take a slow breath in, hold there, take a slow breath out, because you're going to be controlling how to do it, because they can overshoot the gate every time. But like with the innovations with the VCD now and stuff like that, where they can actually see it on the actual computers, they can see the gating, that helps big time too. But the overall answer to your question, yes, we should be coaching every day.
Perfect. Great one. There is one more question, and then I'm going to let Trevin go. Enjoy the rest of his day.
No problem.
So can we do triple phase CT for liver and gallbladder patients with abdominal compression?
That I can't speak on that. I don't know. I'm so sorry.
No, I'm not quite sure what triple phase CT is. It would depend on all the equipment you have available. So perfect. All right, look, thank you, Trevin, for your presentation today. I learned a lot. It was really helpful. And and your patience for answering all the questions from everyone. And thank you, everyone, for these great questions. So just a reminder, next week you've got a free weekend. So there is no session on the 22nd of July. The next session is the 29th of July, and that's the imaging session. And you've got me, so I will be seeing you all in 2 weeks' time. So, and I'm a talker, so bring snacks, come prepared.
Right, it's been an experience. Thank you so much.